Welcome back. We are officially diving into part 13 of our breast surgery coding masterclass explainer. Now, if you were with us for part 12, you know we spent a lot of time breaking down autologous flap reconstruction. Today, we're shifting gears entirely. We are transitioning from flaps to the extremely precise step-by-step coding of prosthetic implants and capsular pathology. So grab your coding manuals and let's get into it. Here is a quick look at our roadmap for today. We'll start with the stages of implant reconstruction, move into the prosthetic CPT code hierarchy, and then tackle capsule and implant management. After that, we'll navigate some critical bundling rules and CCI edits, put your skills to the test with real operative report case studies, and wrap it all up with a quick summary and a preview of what's next. All right, starting with Section 1, the stages of implant reconstruction. To truly master medical coding, we absolutely have to map our codes directly to the physical surgical timeline the patient actually experiences. Before we even think about looking at a single CPT code, we need a solid grasp of the anatomy of the breast and the pectoral muscles. Understanding this anatomy is absolutely critical because it dictates whether a tissue expander or an implant is placed pre-pectorally, meaning over the muscle, or subpectorally, under the muscle. It's the absolute foundation you need before you even open an operative report. Clinically speaking, there are two distinct surgical pathways we're dealing with here. On one hand, we have a two-stage reconstruction. This is where the surgeon places a temporary tissue expander, gradually expands it over time, and then follows it up with an exchange surgery at a later date. On the other hand, we have an immediate, single-stage, direct-to-implant reconstruction. Recognizing exactly which clinical pathway your surgeon took is always step number one for accurate coding. Moving right along to Section 2, let's map these out in our prosthetic CPT code hierarchy. The crucial distinction here is understanding how these core prosthetic codes relate to one another. CPT 19357 is specifically for tissue expander placement. And listen, here is a major key to remember. That code inherently includes any subsequent outpatient saline expansions that happen during the global period. You are not going to bill those separately. Then we have CPT 19340, and that's for the immediate insertion of a permanent prosthesis. Finally, CPT 19342 is going to be your go-to code for delayed insertions, or, really importantly, the expander to implant exchange. Now for Section 3, capsule and implant management. So, as a totally natural immune response, a fibrous capsule forms around the implant shell over time. But when things go wrong, like with a capsular contracture, your coding escalates based entirely on the pathology the surgeon encounters in the OR. It literally ranges from just removing an intact implant, which is code 19328, to removing a ruptured implant along with its contents, which bumps us to 19330. Now, if the capsule itself is tight and constricted, the surgeon might perform a capsulotomy just to score it and release the tension, and that's billed as 19370. Or, at the absolute most severe end of the spectrum, they perform a complete en-bloc capsulectomy. That's removing the entire contracted capsule, coded as 19371. To really ground the clinical reality of CPT 19371 in your mind, just think about what a complete capsulectomy actually entails. A thick, pathological, and often totally calcified capsule is completely excised along with all the intracapsular contents. Understanding just how extensive that tissue removal is helps you immediately spot those key phrases, like complete excision or in block, when you are digging through the surgeon's documentation. Okay, Section 4, critical bundling rules and CCI edits. As an auditor, here are the exact traps you want to avoid. First off, never, ever report 19328 for intact removal with 19342 or 19370 on the same breast. It's bundled. Second, a capsulotomy and capsulectomy cannot be billed together on the same pocket. Obviously, you can't just score a capsule and completely remove it at the same time. But here is the really big one. Simply removing and replacing an existing implant with one of the exact same size and shape is bundled entirely into the capsule revision code 19370. However, if the surgeon has to place a differently sized or shaped implant, that actually requires resizing the pocket, which allows you to report 19342 in addition to 19370. And please remember this absolutely vital exception for biologic mesh like acellular dermal matrix, or ADM. This is add-on code plus 15777 used for soft tissue reinforcement in the pocket. When this mesh is used bilaterally, you report 15777 twice on two separate lines, but you never, ever use modifier 50 with it. I can't stress that enough. That is a massive compliance rule to remember. Let's move to Section 5 and put on our auditor hats for some operative report case studies. Let's test everything we've just talked about with a real-world scenario. Our first case study note reads, a complete, thick, calcified, fibrous capsule is completely excised. A new cohesive silicone gel implant is placed into a newly prepared prepectoral pocket reinforced with acellular dermal matrix. So when you see this specific phrase in an operative report for a patient with severe capsular contracture in the left breast, how exactly do you assemble those codes? All right, breaking it down, we start with 19371 for that en-bloc capsulectomy. Next, we use 19342 for the delayed insertion of the new implant into the newly prepared pocket. And finally, we add plus 15777 for the ADM. All of these codes get appended with the left laterality modifier, LT, and we drop a 51 modifier on the 19342 to clearly denote a multiple procedure. Awesome. Let's look at our second case. This is a very standard reconstructive conclusion. Bilateral tissue expander exchange for permanent cohesive silicone gel implants with bilateral ADM placement. I want you to think back just a minute ago to the rules we covered regarding bilaterality and biologic mesh. This is exactly how you apply those tricky modifiers. Notice how we correctly apply modifier 50 to the bilateral implant exchange on code 19342. But, just as we discussed, we strictly list 1577 twice on its own lines without modifier 50, perfectly following those CPT guidelines. Nailed it. Bringing us to Section 6, our summary and a look at our next episode. We have covered some incredibly complex coding hierarchies today, so I highly recommend using this 4-step checklist to verify the surgical sequence before you finalize any audit. First, identify if the placement was immediate or delayed. Second, confirm the pathology. Was the removed implant intact for 19328 or ruptured for 19330? Third, carefully distinguish a capsulotomy scoring from a complete capsulectomy excision. And fourth, always double-check your laterality and make sure that ADM modifier rule is followed flawlessly. So, I'll leave you with this final thought. Are you ready to tackle the coding complexities of aesthetic and corrective breast surgeries? Because mastering the codes we covered today sets us up perfectly for Part 14, where we are going to dive deep into mastopexy, breast reductions, and complex revisions. What kind of tricky new guidelines are waiting for us there? Well, you'll just have to join us for the next explainer to find out. Keep learning, keep auditing, and I will see you next time.